Yes. So I'll be sharing some of the challenges that I've encountered in operating patients with corneal opacities. So we do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. This was a 74-year-old female, one-eyed, known case of corneal opacity in both eyes since childhood. Her right eye, which is the lost eye, has been operated for PK twice and probably has had an old funnel RD in that eye for many, many years. And the patient has somehow managed all her life with this left eye that is there. Now, when she presented to us, we got a call from the from the referring surgeon that the better eye, which was being operated, capsulotomy was attempted and probably completed. A first chop was being attempted, and then because of the poor view, the surgery was rightfully and correctly stopped at that point, closed the eye, and decided to refer in the best interest of the patient. So when she presented to us, she had hand movement vision. PLPR was accurate, fortunately, in all quadrants. This is her clinical examination. Even in bright light, both the cataract as well as the cornea were almost completely white. So it was difficult to make out if any rhexis was actually completed, not completed, half cut, split. We had no clue what was going on. The corneal thickness, like you can see, is not very high, which means that this is not an endothelial disease per se. It's just a corneal bad opacities, which may have been smallpox induced during her growing period. And this is the other eye, which has had a failed graft multiple times and a funnel RD in that eye. So the better eye, which we are planning to operate, which is, halfway in the surgery, has an attached retina, but that is most important to see, because if that is not there, the entire plan changes completely. So while starting the surgery, we've seen and we've learned quite often from corneal colleagues as well as expert surgeons to use endo illuminators from the sides to try and help and visualize and see if we can find out any clear areas that are there. But even with the endo illuminator from the side, I'm really struggling to see if there is any area of capsulorhexis or any flap that I can see. So I gave up the idea of the endo illuminator in this case right from the beginning, and I thought, let me first stain and see if some stain picks up. And if you notice here, some fluffy matter is already getting released, which means at least there is some opening somewhere, and I could get a rough idea that this is probably the area where part or at least complete capsulorhexis has occurred. The rest of the capsule has taken up some stain, and this is the area where probably some amount of a small capsulorhexis has been done, and it's a white mature cataract. So I decided to take my chance, and in this area of the opening, very small area, I'm slowly but surely sculpting and trying to divide this nucleus, because I've realized now that this cataract is very, very brittle. So it's behaving like a liquefied mature cataract. I was hoping that it would be a little dense so that I can chop, but it wasn't very dense. So I'm making sure I'm trying to bring the fragment towards the central area, which is the area where I know that the capsulorhexis is open, and I'm very conscious of making sure that my chopper remains posterior to whatever the capsulorhexis margin is. And I'm going to make sure that my right hand doesn't go anywhere except for this very small central area where the capsulorhexis is open. So whatever maneuvers that need to be made with my left hand. I'm also very conscious, because I don't know, this rhexis may split somewhere, it may have an extension somewhere. So I'm keeping my parameters very low. So very low intraocular pressure of 20, which is equivalent to a bottle height of about 35 centimeters. A very low flow rate, less than 20. And a moderate vacuum vacuum appropriate to the density of the cataract. So about 300 to 350 vacuum. And slowly but surely, I'm bringing it in the middle, subdividing this relatively soft nucleus and removing it as much as possible in this central safe zone that I'm able to see. Even with this editing, this video this surgery took really long and a lot of sweating as well. And fortunately, most of the nucleus I feel now is out through this central area, and now I can at least see some sort of reasonable kind of glow and some sort of cortex that I'm able to see. So now, while removing the cortex, this is the case where definitely bimanual irrigation aspiration has a distinct advantage, because you are able to access and ergonomically move your probes in all different directions, whether it's subcapsular or below the corneal opacity, by keeping your other hand free. And here, swiping movements are extremely important. You don't want to pull too much because you don't know about the zonular integrity as well. And only after I bring the cortex to the center will you see my vacuum building up. So when I'm actually in the periphery and notice few chips of cataract are also coming, and therefore I'm having to crush them with the irrigation probe into the aspiration probe. Some of them do get dispersed off in the angle while removing this cataract. So making sure that the cortex is removed decent enough, at least from whatever I could see. And even before changing hands, I do inject dispersive viscoelastic to make sure things are okay. So this is the picture. I can see some amount of opacities. I'm not sure whether it's in the anterior capsular area or it's on the posterior capsule, but most of the entire capsular bag looks to be open. And therefore, I did decide to go ahead with IOL implantation. We had counseled the patient for aphakia and all possible complications. But because I'm not sure about the integrity of the capsule, as well as what is going to happen during IOL implantation, I decided to go ahead with a 3-piece IOL in such a situation, because it is likely to be the safer option. If I have to go to plan B, or if I have to, if the IOL even ends up in the sulcus, a 3-piece design with PMMA haptics in the sulcus will be a much safer option. So I'm using the injector and using my proprioception to dial the intraocular lens in the capsular bag, I'm notching here with the Lester hook to look at whether the capsule is actually covering the intraocular lens, which I felt it was doing quite okay. Any incision more than 2.2 is a great idea to suture, but definitely in such an eye with such a compromised cornea, it's a great idea to suture even a 3.2 millimeter incision. And you'll notice that I've taken 2 sutures here to make sure that there is absolutely no leakage from the wound occurring. I'm doing viscoelastic removal now, and I get some sort of sense of some amount of, making sure that this part was actually subcapsular on the anterior capsule margin and not on the posterior. And I noticed a small nick in the anterior capsule, which fortunately had not extended, which I now converted into a capsular excess margin. So if I can go back and, sorry. Yeah, so this is how the patient did, quite okay, reasonably. The uncorrected was 660, best corrected was 618 parts, but she is extremely happy. So obviously such eyes are not going to have the 6669 kind of vision, but functionally she was much better off than what she had been in the last 3-4 years. Because naturally, patient was also very scared of getting operated, being the only seeing eye, and so with so many surgical difficulties. This was another 70-year-old male, both eyes nebulomacular corneal opacity diagnosed since a very long time, both eyes cataract, a brother of an ophthalmologist, practicing ophthalmologist, who's been seeing him for all his life, and known case of very high myopia as well. So all conditions combined, a bad cornea, a bad retina. He's been using myopic glasses of -13 ever since he was 18 or 20 years of age, and his visual acuity is only, counting fingers, 2 meters. He referred it to us for cataract surgery, and this is how the patient looked. This is the large central corneal opacity that the patient has. Fortunately, if you turn it on the retro illumination, you can get a reasonably decent view. But if you actually see it on diffuse illumination, it's quite a dirty cornea, particularly in the area where we are going to do cataract surgery. Keeping in mind the risks of penetrating keratoplasty, we discussed with the patient and we decided that we'll attempt to do a cataract surgery, and if everything goes off well, if he's reasonably okay, nothing else later, and if nothing works out, then maybe a penetrating keratoplasty at a later stage can be considered. So all this haze that you see is the corneal haze and not actually the cataract or the cortical opacities that you often see. And I think however good you may feel initially, these are the cases where staining with trypan blue is of paramount importance, because you will need that intraoperatively as well when the surgery is going on. So if you notice here, I'm struggling to see centrally whether any nick has been made or not, and therefore in the area where the opacity gets over is where I'm trying to position the flap, which I can then manipulate to my ease. And I don't want to make a very large rhexis here, because I'm aware that if my view intraoperatively gets bad and if I end up with a relatively serious complication, I need a good anterior capsulorhexis support as well to consider. Once again, many of these cataracts are not very dense. They are more cortical and more fluffy in nature. Like I'm realizing now, it's neither here neither there. So it's not very soft and not very dense to chop very easily. But keep following the principles, keep the occlusion on, and use lateral separation as much as possible to try and break this cataract into multiple small pieces. Again, use very low fluidics, low intraocular pressure. Here it's 20, but you could keep a 30, 40, whatever is more comfortable, but keep it lower than your normal, and a very low flow rate, because it is the flow rate which is going to decide what and how fast you are going to attract. So even though your cataract surgery may occur faster with a higher flow rate, you have also very high chance of catching unforeseen things like the iris, like the posterior capsule, like the anterior capsulorhexis, which again is not very visible in this eye. After the lens was removed, I ended up in quite often what we end up seeing is what is known as this plate, which is not amenable to IA, where there is no anterior cortex to catch, and therefore you'll notice I've turned my bevel downwards, having reduced the power now to only 20, and having turned the bevel downwards, I've occluded it and kind of prolapsed it into the anterior chamber. And once that prolapse occurs, once you occlude it facing bevel down, that's when you can easily remove it. IA, once again, as I mentioned, it's very important to use bimanual irrigation aspiration in such eyes. Occlude, swipe, and only once you get to the center will my vacuum actually go to 250, 300. Until that time, it will always remain between 50 to 100, because we want to aspirate in the center and not in the periphery where you can catch anything as well. So again, swipe, you can get larger areas of cortex at one go, as well as you'll be putting less stress on the zonules as well. And such eyes, obviously, there is no question of considering toric or other forms of IOL. A simple spherical monofocal IOL is of the most paramount ease. After the IOL was in place, I realized the rhexis was much smaller, and such eyes may have inflammation post-operatively. So chances of phimosis are higher, and therefore I'm increasing the rhexis size, what was described by us many years back as initial small and definitive large, and going ahead with viscoelastic removal. The patient recovered reasonably well, has good functional and ambulatory vision, and the patient, and fortunately the ophthalmologist, is also very happy. So I think proper assessment on a case-to-case basis, like we have for endothelial diseases, here I don't think there's one good go-to chart which we can follow, that if this is there, do this. So on a case-to-case basis, decide on the type of cataract, the location of the corneal opacity, the one-eyed or bilateral-eyed nature of the patient, how long he's been living with this opacities. All of these things are extremely important. The aim in these surgeries is to provide a functional vision, and we are not looking at refractive outcomes and other things. I think great credit does go to the newer generation microscopes. If you turn on your full coaxial illumination, it's astonishing that what you saw on the slit lamp where you thought, how am I going to operate? But on table, you do see reasonably well through the new generation microscopes. Trypan blue use is of paramount importance. Use tricks like using endo illuminators from the sides, and several surgeons have shown using chandelier illumination from the back to increase the glow that you see by keeping the microscope off. And counsel, I think that is most important. Do not operate at the first visit. See him once, even though you want to operate him, you're going to operate him. Call him back in 1 month. Ask him to bring his other relatives also. Counsel them at least 2 or 3 times for the prognosis, as well as the possibility of multiple surgeries, ending up with a drop nucleus, ending up with a PK, so on and so forth, and prepare them for the worst before operating them. So thank you so much for listening to this talk, and I would value Dr. Fogla's comments on how you would think of approaching patients with corneal opacities like this, which are not endothelial diseases per se.
So the mic is there.
See, I completely agree with you, because a lot of these patients are elderly patients, and they come back and the opacity is not of recent onset. The opacity may have been there for long duration, and they are coming to you because of the development of cataract. They are finding it difficult, so they are not expecting 6x6. So you are completely right in your approach that first remove the cataract, and if they are happy with that vision, it makes life much more easier for them than to do a corneal transplant combined with the cataract, because that requires much more post-operative management, care, and the risk of rejection, which can take away the vision whatever it is required. But one small point that I wanted to make was, in these kind of cases where sometimes if you really feel that phacoemulsification is a little bit more challenging, maybe doing a manual small incision cataract surgery may be a better option for somebody who is not as skilled as you, and so because that thereby you just make a capsulotomy, prolapse the nucleus and bring it out, you can still achieve the same. Because with limited visibility, it looks good when you start out with the red glow, but once you hydrate and you're dealing with the nucleus, the red glow goes away, and then if you're not able to crack the plate, then you're in a dilemma as to how far you can go.
Excellent point, sir. Any other comments from?
Yeah, one question in the first case. Even though I knew that the outcome was good, even while watching it, my heart was still in my mouth right now. With an open capsule, somebody has already attempted a surgery earlier. You don't know the integrity of the capsule. Will you change your choice of viscoelastic? Would you go for a heavier, or would you continue with the same viscoelastic? Would a heavier be more detrimental?
So the excellent question is that if you use a very heavy cohesive viscoelastic, say Helon Phi or Helon GV, that itself can be detrimental for the fact that if there is a nick or if there is a split, that heavy viscoelastic itself may increase that split further. So I would definitely not go for an extremely heavy cohesive viscoelastic, particularly until I'm reasonably sure or reasonably confident that there is a strong opening in the center.
Thank you.
Yes, ma'am, please.
So this is Dr. Swadhyagrawal from Kolkata.
Yes,
so for the second case, the way it looked like a stable refraction, and it was more of an stromal epithelial opacity. So you left behind you targeted a functional refraction, but why not a refractive outcome, like leaving this behind a -2 cylinder? Like if the patient had been economically, could provide for it, would you have opted for a toric lens?
So the toric, the problem or the advantage of a toric or the disadvantage is that it works only for a regular irregular astigmatism. So these patients, I should have probably got the topography and the pentacam as well. These have very irregular corneas. So there is no regular astigmatism of 90 degrees where you can decide which place the IOL would be able to correct it. So in any case of irregular astigmatism, it is best to avoid a toric IOL. So the cost was not an issue for this patient. In fact, we charged much more than we would have charged for a normal toric IOL for him.
Even if the astigmatism was stable, for irregular astigmatism, you wouldn't
No, so any irregular astigmatism, whether it's stable, unstable, any irregular astigmatism, no toric IOLs. Okay, so I think we are run out of time for the course. Thank you so much, everyone, for staying back in this lunch hour. And thank you so much, sir, for coming and gracing our course. Thank you so much.
Excuse me.